first.
There you
For the record, I think that the live shows up after we've actually
go.
gone
That's
live.
for the record? Okay.
Yes. Great, so we're continuing our conversations around Act 167, healthcare reform, and we have with us Devin Green. So take it away, Devin. Great.
Okay. Okay, I'm just gonna hold on. Full screen mode. There we go. Okay. Hi, everyone.
Hi.
Devin Green, Vermont Association of Hospitals and Health Systems. Thank you for having me in this afternoon. I am going to touch on Act 167 and the AHEAD model. But first, I wanted to answer your very existential question from yesterday. What is a hospital? And so I have a couple slides of what makes a hospital unique. And then also within hospitals, different sorts of hospitals and how they're paid and generally defined by the federal government and Medicare. So first, I'll just say, hospitals are unique in that there are several national requirements for hospitals, including that they have 24/7 ED. That emergency department is governed by EMTALA, which is a long acronym, but essentially it means that emergency departments must take whoever come in there. They must screen them, stabilize them, and not turn them away. They must be there as a backup for complications during outpatient settings. And they have not some, but not all, have specialized capabilities such as neonatal care. There are several specific Vermont requirements with hospitals as well. There's a provider tax of 6% levied on hospitals, hospital budget regulation, build back funding for regulatory duties of the Green Mountain Care Board, quality initiatives, and the healthcare advocate. And then hospital report cards, which are reporting requirements where hospitals talk about nurse staffing ratios, quality measurements, and a lot of other good information. Another thing I wanted to highlight around hospitals is their emergency management component. So I think this is another thing that sort of sets them apart from other settings, which is that they're very integrated into emergency management. And you don't always hear about these responses because luckily they're unnecessary, but when, everyone knows about COVID-19 and the vaccination response, testing, everything there. There was also hospital response during flood events. There was literally no place else for rescuers to bring people. And so, during the Montpelier flood, they brought them up to Central Vermont Medical Center, and Central Vermont Medical Center kept them there. Things that you may not have heard about was there was a lot of preparation for the solar eclipse. Our population doubled. We knew that cell towers might be jammed. People had to get on ham radios and practice with that in case those things happen. So there are a lot of things that happen behind the scenes in emergency management that you hope will never need to be used, but takes a lot of time, preparation, resources, and people.
What's port strikes?
So there was, it hasn't happened yet, but there were a couple of instances of worker strikes potentially at the ports, and that would have been very disruptive to the hospital supply chain. And so there were preparations around what should happen if that strike goes into place. How will we manage the supply chain?
So it's like the IV fluid problem that could.
Yes, and that was due to the hurricane in North Carolina hitting the Baxter facility. And that actually did happen. And so that took, supply chain meetings, conservation measures, all of those things. So broadly, those are some of the hospital functions. I want to get a little bit into what are the different types of hospitals, just to make sure we have a shared understanding that a hospital is not a hospital. So the first up are the critical access hospitals. These were designated specifically by the federal government to improve access to healthcare in rural communities. They have several requirements. They must have 25 beds or fewer, average length of stay of no more than 96 hours, and have a 24-hour emergency department. They get cost-based reimbursement, which is essentially they have reporting requirements, and then for Medicare, they will be paid 101% of the cost. And then they claw back 2%. So really, they're getting paid 99% of the Medicare costs. So that's a Medicare designation for them. We have 8 critical access hospitals, which are listed here.
Why are they clawing back 2%?
Great question. It's federal government. It used to be 101%. And then I think this was just a money saving budget thing. So they took the 2%. That was paused during COVID, and then they've since gone back to it. So we're back at the 99% instead of 101%. We also have a Medicare dependent hospital. We have one hospital in Vermont. And I'm sorry, I forgot to put the purpose in here, but that is basically to support a safety net hospital where 60% or more of the inpatient days or discharges are from Medicare patients, and they have 100 or fewer beds, and they're located in a rural area. So this is recognition, again, of a rural hospital by the federal government needing additional support. And Vermont has one Medicare dependent hospital, which is Brattleboro Memorial Hospital.
And if I could comment,
Yes, please.
since that's my county, Wyndham
Yes.
County, they're terrified, frightened of losing that designation
Yeah.
because they would not survive. So that puts a lot of instability in their world.
Yes.
And of course, that was before this.
Yes.
Saying there's a bit of fragility there that we need to know.
Yes, I think that's right.
And how is their payment? So they receive,
They get an additional payment. So if they would lose money under regular Medicare fee for service, they get an additional payment. Community hospital. These are what I think we typically think of in terms of our mid-sized hospitals. They are paid on Medicare's sort of regular fee schedule, which is a flat rate based on average charges across all hospitals for specific diagnoses. I do want to be clear, and I know that we've been hearing Medicare should be paying 100% of the costs. I will say that when you go onto the Green Mountain Care Board's website, they look at the sort of cost coverage, and they have Medicare there at about 85% of costs. For 2023, and in 2022, it was at 78% of costs. So it doesn't, while the goal is for it to be 100% of the costs, it is not there yet.
how does that compare with, say, other community hospitals across the US? Where are they? Are they also at around 85%?
In general, so I would want to look at the hard data. What I typically hear from other hospitals is that Medicare does not pay 100%. We have 4 community hospitals with Rutland Regional Medical Center, Central Vermont, Northwestern, and Southwestern. And then we have our academic medical center, which also has its own requirements. So must be a medical school or affiliated with a teaching hospital, have a residency program, typically tertiary care capability, which is, you know, a higher trauma level, being able to take complex patients, and then have research activity. And what the federal government does in recognition that, you know, a teaching hospital is sort of inherently not efficient because you are teaching students and need to take time to do that. They have graduate medical education payments to offset some of the costs of the residency program. And our tertiary care center and academic medical center is the UVMMC. But I do think that brings into the equation, I think a lot of times, and what I was hearing with the AHEAD model conversation is like, why are we even doing the AHEAD model? Let's just do global budgets our own way. Let's just do things our own way in terms of paying hospitals. And Medicare is a big portion of our reimbursement and who pays us. And so Medicare defines a lot of things. They've defined that AHEAD model. Really hard to do a global budget program without Medicare. And if Medicare doesn't want to do the program that we set up on our own, then it's really difficult for hospitals to change their practices because they have this huge chunk of patients that are going by different rules.
Wouldn't the waiver that we have allow us to do it our own way?
No. Because with the all-payer model ending, what the federal government has offered Vermont is the AHEAD model. They've said specifically, we don't want to do state-specific models anymore. We want to do a model that we can offer to multiple states that's the same sort of model. And so here's what we have, sort of take it or leave it.
So that's how that happened.
Yeah,
Medicare
yes,
determined that.
yes.
No, can't we still get waivers? We can still get 1115 waivers to
For Medicaid,
change our model though, right?
Step,
you can go ahead.
for the record, no 911, not this one. There are 2 different things.
Yeah,
The head model is just like innovation through CMMI. Waivers are Medicaid specific through CMS. They're just 2 different things.
I think 1115 waivers are primarily Medicaid, and then there's an 1115A waiver, which is how Maryland did their Medicare thing, I think. But again, the federal government doesn't seem interested in letting states go their own way when it comes to this sort of thing.
Do we have a sense across all hospitals, or I'm sure someone keeps this specific to hospitals, of inpatient care, approximately what the payer mix is? Because we're talking the importance of Medicare designation. What percentage of inpatient care is
Yes, at least 30% is Medicare.
for inpatient care?
I would want to go check that, but yes, that's my understanding. And it might be higher for inpatient care. I will follow up on that. It might be higher for inpatient. So, this is our hospital spend. We've been talking a lot about how hospitals spend money. And I do want to, you know, be transparent. This is always transparent. It's on the Green Mountain Care Board's website. It's available. Primarily our spend is labor. And then we do have things like pharmaceuticals, medical, surgical drugs and supplies, and healthcare provider tax as fairly big ticket items as well. But people are our main cost drivers. There was an interesting discussion this morning about, do we do delivery transformation? Do we do payment reform first? How does it, like, who came first, chicken or the egg? How does this work? And I'll just say that the payment methodology does inform transformation. And I think this is what hospitals are engaged in transformation. We are at the table. We want to do this work. We understand the necessity of doing this work. But you have a different approach under a global budget than you would under a fee-for-service program. And we need, and maybe this is where the technical assistance comes in, we need to understand how we can change when we don't have a strong margin and money to burn. How do we manage that change over with the services that we offer without any sort of cushion? You're not asking you for a cushion. We're just saying this is very tricky. If you have a global budget, you could look at that and say, well, great, now I can afford my my maternal unit and an orthopedic can go away. And we do SUD and maybe we do these other programs. And we know that the federal government or the Green Mountain Care Board will likely ratchet down costs because it's been presented as a cost constraint program. If you have fee for service, you need to work within the confines of fee for service. And so, you know, we would probably need to have that orthopedics program in order to help sustain the birthing maternal program, unless there's an increase to the reimbursements of those services. And at the bottom, I just note here that Medicare is really important in this conversation if we want to go in one direction and not have a foot in two canoes.
I'm sorry. Could you do a prospective payment system where while you're transforming, we keep using the word transformation.
Yeah.
Could you work off of just a prospective payment system based upon previous fee for service while you ratchet down on some things and build up in others?
I think that is an option. And I know that so Medicaid has been operating on a prospective payment system, and it's actually our hospitals have appreciated that effort, but since they are just a portion, and fee for service is still largely what we're dealing with, we haven't really had the room to take advantage of the prospective payments to change our delivery system. So reference-based pricing has been in the conversation. I will be perfectly honest, these numbers, you know, we took these numbers from the fact that the report that came out from the Green Mountain Care Board had our commercial pegged at 289% of Medicare. And what we did with these numbers is applied with the understanding that our commercial is 289%, we applied the 200%, and that's where these numbers came from and the impact. I am happy to have Patrick, my colleague, go into the data more with you, but the bottom line is that reference-based pricing at 200% would have really big impact on our hospitals. Which isn't to say that it would, you know, we are interested in all the options. So we are interested, like, we can explore reference-based pricing, but even Chair Foster has mentioned that 200% too quickly will have a negative impact on hospitals, and we agree with him on that.
I keep asking questions at every single slide. They keep having new thoughts. I mean, if you're doing reference-based pricing, there's no hard and fast rule that it has to be the exact same for all types of services.
Mhm.
If you're trying to incentivize delivering different types of care, you set reference-based pricing at a higher percentage for the types of care that you're incentivizing and lower the types of care that you're possibly transforming, then this chart would not hold at all.
Yeah, can we have the background data that they used for this model?
Yeah, I'm happy to give, I mean, I don't have so there's the Green Mountain Care Board report. We took these numbers from the Green Mountain Care Board report, and then used the multiplier on the 2023 hospital budget actuals.
If they
Yeah,
consider
also-
this data or the table that they used for this chart would be helpful.
I just want to throw it.
But you're assuming the same services that historically you've always provided.
Yes.
Okay. Leslie?
The auditor also did a report on reference-based pricing, maybe last year, which also looked at Montana's a state that has had a lot of success in certain arenas. So there's other than that.
Yeah, although Montana is backing away from it.
Is that?
Yeah.
Okay, so that's what happens, right? Run in, run out.
Yeah,
Can't keep up.
I know. Never a dull moment in healthcare.
No.
So the Act 167 Oliver Wyman report, again, we are happy to participate in transformation. We did have some concerns with the report. We are moving beyond the report and working on, with this new consultant and working on transformation that way. We're excited because the consultant is going to meet with hospitals and really dig in pretty far, it sounds like. But just one illustrative example of, and I think it's been painted as hospitals responded really politically to the recommendations of the report, but we have valid concerns about those recommendations. And I think an example of that is the recommendation that some hospitals close their maternal and obstetric care because of low volume. So they cited an article that said there was a difference in quality between hospitals that were rural that had 460 births versus hospitals with higher births than 460. I can tell you now that the only hospital that does higher than 460 births in Vermont is UVM Medical Center. But what's more is that article drew a different conclusion than closed down a birthing center by saying these birthing services are very valuable, and what we need to do is support them with quality improvement measures. Beyond that, Vermont is #1 in the country for maternal health. And so I think there needs to be context around some of these recommendations and further thought put into it.
Daisy, did you have a question? And
I
then
do.
Mari?
I just wanted to pick up on one thing you said. You said you're moving ahead with transformation with your own consultant.
No, with the AHS consultant.
Okay, good. Because we just heard from AHS and it sounded like there wasn't
No,
collaboration.
no.
That's key because.
Yeah, no, we were happy to see the Rural Health Redesign Center was chosen because they have experience with rural hospitals in central Pennsylvania, and they've worked with global budgets too.
The other question or just point I wanted to make is, Vermont is also #1 in the country for access to mental health care, according to Mental Health America. So we all know that's just not true in our experience. So I just want to point that out.
Yeah, I appreciate that, but again, I fundamentally disagree with closing birthing and maternal services in rural communities just based on a number. And it felt like that was what happened in this report. And just to add on to that, our hospital went and talked to Oliver Wyman about that and talked about the efforts that they have made and the quality programs that they have in place. And the report was changed, and then it was changed back to the original recommendations, and sort of blindsided them.
All right.
I have a general comment, I get it that hospitals are struggling. I love the hospital that I work at. And I'm grateful for the care that it provides. And I think the criticism of how hospitals responded, and in particular, UVM Medical Center, to the Oliver Wyman report was really unfortunate, and especially the way it played out publicly. I think there was enough misrepresentation about a very complex topic that caused misunderstanding statewide in the community, and at a time when these are recommendations.
Yeah.
At a time when, because our systems are failing, are heading towards failure, we need everyone as adults at the table, working together and not pointing fingers at one another. And that's the impact I felt that the initial reaction the UVM Health Network had, in some of the unilateral decisions that the hospital made. And I understand it's within their power, but I would like to see all of the stakeholders making really good faith efforts to not be doing that, and trying to help the public understand what's really going on instead of doing this.
Yes, and I am with you, and I just want to provide extra context. And so I think the intention makes sense. I think hospitals do need to change. We are at the table to do that, but I just wanted to give further context about we are very much looking forward to digging into these recommendations and looking at other potential recommendations or things that we can do to make sure that, again, there is further information, context, and not just a conclusion based on a number where, the person who wrote this article was horrified to hear that it was being used this way. Like, we need to make sure that we're digging in really deep on these things for our communities.
Right.
And I'm really hoping, as Representative Cordes says, we do have everyone at the table. So hospitals, we are definitely at the table. I'll get into some of the things we're working on. And I know that the insurers and other providers are also in dire straits. But I do want to make sure that we are viewing this as a system and different, and the way it might have different impacts, and also understand all the options that are out there. So what this chart shows is the rate increases for the last 8 years. Hospitals are the purple, and the individual group. So this doesn't include the small group. This is the growth in the individual group over the last 8 years. And this is all just to show that, yes, hospitals are a big part of the problem. There may be some more opportunity to be had here as well.
Well, go ahead.
I'm
trying to wrap my mind around how you can compare insurance rate increases with hospital rate increases, because they do different things and they work in different ways. And, you know, for example, hospitals get 340B discounts. I don't know if that's reflected in here, and insurance companies pharmaceutical costs for insurance companies are going way up, and I don't know how that's, if it's apples and oranges in this slide. I think there's a lot of detail behind this
Yes.
slide.
I think there is, it's not as it's not as easy as that. It's not going to be a one-to-one, you know. There are other things going on with insurance companies that play into the rates. There are things that happen at hospitals that play into the rates. But again, I know that hospitals are a large part of this equation. It's not all of the equation. And are there other opportunities in other parts?
I think, I mean, in my mind, I'm just looking at it and I'm equating. I'm looking at it and I'm asking the question, are we asking our individual market to subsidize the rest of the market? Where, I mean, I think a better represented graph would be if you had the average increase of all payer mixes in there. I mean, where, like, if we had a column for Medicaid, Medicare, where would those fall in relation to the blue line? I mean, frankly, I find this a little alarming just because we're asking, it's almost like we're asking the groups that we actually have control over their rates to subsidize the rest of the system of care.
I should be clear that these are the rates. I think the question sometimes can be, okay, the hospital rate went up 2%, but the insurance rate went up 9%. How, you know, what is the correlation there?
Well, yeah, but did it go up 9% because all the other payers either went up 0 or negative, sometimes in the case of Medicare, or 1%? I mean, we really only have control over the rates. And when I'm talking about rates, I'm talking about the insurance rate. We only have control over a very, very small segment of the whole market.
Right.
I'm
And the hospital is supposed to be,
in that.
the hospital has been characterized as a large part of that rate increase, right? It has been said, the rate increase is happening because of hospitals. And I think there is, again, it is happening because of hospitals, but I think what I want to make sure is that we are focused on the entire system. So what are other opportunities to change our healthcare plans or increase our risk pools to also help bring down the rates while we work on transforming hospitals?
I appreciate you reminding us to look at the entire system. We do a lot of that in here. But I really am concerned that, you know, we have you here to talk about hospitals. And it feels like what you're saying is that we should instead look at the insurance companies who are in no better situation than the hospitals are right now.
I am saying both.
Yes, we're aware that they're also in a bad situation. And I don't want us to deflect our attention from hospitals over to the insurance companies. I just want to make sure.
I'm not asking you to deflect, I'm asking you to include.
We are.
So I just want to make sure that that's happening too. Because if you look at a similar county in New York, similar demographics. So I looked at New York because New York is the only state in the nation that has peer community rating. No other state has peer community rating. So that's the most comparable state to look at in this case. And I picked a county with a similar population to Lamoille County. And if you look at Lewis County, you can just see a difference in the way the health insurance market works there. And is there opportunity to make changes in our own market that would actually help the insurers and reduce costs? Right now, we restrict our plans to standardized plans. We don't give the insurers a lot of leeway for producing different plans. And so are there things that we can do? In Vermont, we have 7 plans. In New York, we have 28 plans.
Do we haven't, oh,
No, go ahead.
I was gonna say, do we have any idea of the average price for services in Lewis County at a hospital compared to Lamoille County?
I can try to get that information.
I think that would be valuable.
Mhm.
Lori and then Mari?
Can you explain that a little bit more? Like, I guess I have actually never seen this before, and I don't. Important information for us to know. So when you say we restrict to 7 plans versus they have 28, so do they have 28 because they have like more and provide insurance companies offering plans, or is it that we have something in statute that prevents? There's
Yeah.
probably a lot of questions that we can
I
come
know.
back on.
And now that I'm thinking they do have more insurance providers. I can go back and check, but they definitely have more insurance providers. And so that could be part of it. I also know that Vermont made a conscious decision to have standard plans. And I may just be, I may need to go back and look at this more, but
That's fine.
Vermont
That'd be
has,
helpful.
Vermont wanted to have an apples to apples comparison.
Okay.
And so they created sort of standard benefits, standard copays and those sorts of things for health insurers to follow so that people would have an apples to apples comparison. So there wasn't a lot of room for insurers to work within the their actuarial value level.
Okay, gotcha.
Except for a couple of individual plans that are, sort of creative plans that they can do.
Okay. Yeah, so I just find this interesting, and so any other information can be great.
Yeah.
Mari?
On that vein, apples to apples or apples to oranges, I would want to know specifics about the bronze plans and how they compared. Are they exactly the same? And then anecdotally in my work at UVM Medical Center, over the years, it's been a sort of a constant issue where when we have a New York patient and we are trying to set up care in New York, the services that are provided to New York residents are not adequate. So the services that New York residents are receiving have not, in some cases, we've had to delay discharge because it wasn't safe to send someone home to upstate New York because the home health services or whatever other services just weren't available for that patient. So it feels more like apples to oranges than apples to apples to me.
Yeah, and I can tell you the plan design is probably different than our plan design. And we may hear from the insurers that we've looked at all different types of plan designs. There's no way to make it less affordable. I don't know if we have, and I don't know if it's the right suggestion, but just like the Oliver Wyman report having some good recommendations and bad recommendations, are we looking at this also?
Other questions? Okay.
Other
I have a
things.
question.
Oh, I'm sorry. Brian,
It's a-
get the slides up. I'm not seeing you.
Yeah,
Okay.
you can't see me, I understand. I didn't want to interrupt, but I figured, and I don't know if it's coming up, Devin, because I'm trying to look at the presentation on the website and it's not working for some reason. It keeps crashing, so I don't know what that's about. So I'm just gonna ask. And if it's coming up, I'll wait. But what I'm wondering is, we got this thing, two questions. One, we got this thing from Blue Cross Blue Shield where it showed us the different prices of procedures at various locations, and it showed that some things were like 4 times as much a UVM medical center than other locations, both hospitals and other community settings. So the one question I would have would be, do you, and if you can't answer it today, it's okay, but it would be, why is UVM Medical Center so much more expensive than the other hospitals? And then the second question would be, if at some point we can look at how much money is going to administrative costs, like the executive salaries, just to see the percentage of spending. Thank you.
Yeah, thank you. I don't have those answers today. I am happy to get them to you and happy to discuss that more. I do want to dig into the administrative piece a little bit, especially because administrative costs are, if we could reduce that, that would be helpful. They are beyond CEO salaries. They are going to quality initiatives. They're going to compliance. They're going to bill collection. They're going to prior authorizations. There is a lot to that administrative piece that is valuable work for the hospitals. So I just want to make sure that there's an understanding around what is encompassed by administrative costs.
I looked at that report and it includes things like quality reporting and accreditation also, coding, eligibility work. Do you think that any of those are things that we could cut?
I think that the prior authorization piece is a really good start in terms of cutting administrative costs. I wouldn't want to cut quality initiatives. And I think you'd have to do pretty detailed analysis. Billing and coding are things that are necessary to ensure that hospitals get paid for the work that they do. Unless we're changing that system.
Global budget, yeah.
Right.
Yeah, I agree.
Yeah.
I mean, I'm looking at the report that you pulled this directly from. I just feel like, you know, everything that I'm looking at that you pulled that 30% from, it looks, as far as I can tell, pretty essential and fundamental to the operation of a facility.
Mhm. But you're right, if you have global budgets, that you still have the patient billing portion that you have to do, but I don't know, we saw a lot of potential there initially when the global budgets came out. Again, it feels like there's not enough details from the federal government at this point to understand if it would give us that freedom from administrative duties, but that's where we saw some of the potentials not having to do those administrative functions or certain administrative functions. There was a report that came out about the insurance markets and looking at if the federal subsidies go away and looking at reinsurance. I mentioned the age rating. I don't necessarily think that's a good idea. I know. In the spirit of no stone left unturned. The other piece that I think could be teased out in the healthcare transformation process is care coordination. I think Vermont has done a good job in setting up some care coordination. I think there's ways we could do it better. I think sometimes there's overlap or, there's you have the care coordinator who's working with the health insurer, you have the care coordinator who's working with the hospital, you have the care coordinator who's working with various agencies. How should we approach care coordination to ensure that it functions really well and for maximum impact? We have coverage mandates. Again, those are all good things for Vermonters. I don't necessarily know if it's a good idea, but in the sort of vein of putting all things on the table. And then are there ways for expanding risk pools? I've been out of the Affordable Care Act game for a while, and I don't think we're able to do anything regional. But if there is, we should look into it.
Are you saying that our care coordinators are not coordinating care?
No, I think they are, but
It was, I'm sorry, it was a,
but yeah, I think it's something that we should make sure we're doing it right, and that was a great opportunity. Hospital efforts that are happening now, finally. I wanted to end on this. So hospitals, there are multiple hospitals that are, changing the way that they do things. In terms of usually if you get a patient at a smaller hospital and that smaller hospital is unable to care for them, they get transferred to a tertiary care hospital like UVMNC or Dartmouth, and then they stay at that hospital until they're discharged to either home or rehab or home health. Now our hospitals are working to transfer that person to UVMNC or Dartmouth and then take them back once they are stabilized but still need hospital care. So they're closer to home and the system is freed up for that more complex care. In general, we're seeing that our hospitals are going to have to be taking on more complex, more acute care. So, places like Rutland are probably going to need to take stroke patients that they wouldn't necessarily have taken previously. And so it's a matter of ensuring that we're flexible in terms of making sure that people are at the right level of care, but also at the right reimbursement for that care. So if you get transferred back to a smaller hospital, typically that's a smaller reimbursement and more affordable.
Mari, I have a,
I don't remember, is Rutland Regional accredited as a stroke?
I use stroke, don't quote me on stroke. I just used it as an example. I know I couldn't remember what exactly they were taking on, but
let's
more
say,
acute.
well, let's say it was,
Mhm.
we do need to do that,
Mhm.
and that adds another, I can't remember how accreditation works for things like strokes, and it's another expense for hospitals,
Right.
to initiate programs like that.
Right.
And if a hospital provides stroke care, but it's not accredited, do they get reimbursed less than a hospital that is accredited?
I think what we're looking to do and what hopefully will come out in the transformation work too is, how do we maximize care at the right, the sickest of the sick should be transferred to the tertiary care center. And then where can we keep people at lower levels of cost and care, but still very good care, who, don't have a severe issue, but more of a mid-level issue, to ensure affordability that way. And then we have hospitals that are forming collaboratives to increase purchasing power so that they get reduced costs for their supplies. And we also have hospitals that are partnering with housing and mental health organizations to keep people out of the emergency department. We know that can and sort of stabilize people so that they don't have unnecessary emergency department visits and help reduce costs that way.
Leslie. So what I'm hearing and seeing is that hospitals are getting into the business of primary care. Certainly Brattleboro zoning practices, there are other hospitals in the state that employ primary care, certainly UVM. And I'm not seeing any comments here on the role of primary care in your hospital planning.
Mhm.
And how is that, because primary care, we understand, this is the infrastructure of everything. And of course, we know ahead and primary care, et cetera. So it seems like there's a bit of a gap in what you're presenting. So I just want to understand if I'm missing something in the hospital thinking about their role in primary care.
No, I think the hospital role is very supportive of primary care. As you mentioned, there are a number of hospitals that are affiliated with primary care, and that is all a part of it. Again, that was part of the appeal of the what we have been hearing about the AHEAD model is maintaining those payments for primary care because they've been important in the past with the all-payer model and with the blueprint. And I will say the AHEAD model has taken that piece from Vermont, right? Like it took from Maryland, it took global budgets from Maryland, and it took the primary care work from Vermont. So that is a big part of it going forward if global budgets are to happen.
So do you think, okay, that the hospitals have any responsibility when the market fails and we have deserts and we lose primary care in small communities? What is the role and responsibility of hospitals?
Yeah. Well, I will say that we have examples of Copley partnering now with its local FQHC to ensure its stability. I think hospitals are stepping in when they can. I don't know if they always can step in, which is part of the issue. And again, something we hope to work on in terms of the transformation work is, you know, is there going to be funding that makes it more flexible and more friendly for primary care?
So that when we have lost primary care, Bells Falls, Waitsfield, et cetera, I'm not hearing anybody thinking in your organization anyway, or with your, that there's a response, that there's a response, or that there's an obligation. I don't know. It's a
Yeah,
community, right?
I know.
We talk about statewide community, or, you know, we have a Wyndham County, or, you know, whatever county we're thinking about.
Yeah,
So I'm just throwing that because I'd like to hear back. I'd like
Yeah.
to know what you're talking about.
yeah.
Yeah.
I'm happy to get back to you on that one. Yeah, I will get back to you on that.
I'm gonna ask, you know, I had my, what is a hospital?
Mhm.
I expect you to come back with 3 slides. And this actually might negate a little bit of what Leslie is asking, but I've been asking myself the question lately, why is primary care in a hospital in the first place?
Mhm.
Should it be? Should it be removed from that setting?
Mhm.
Does a hospital really have a role to provide primary care? Or is it done more efficiently, more cost effectively outside of a hospital setting? Which also takes into account that there's not the pressures to order,
Mm.
which drive other costs, hospital costs. I'm just asking the question, why are we putting primary care in hospitals? Why are we not supporting primary care outside of the hospital setting?
Mm.
I know Leslie's like probably,
Well, I think it's a great conversation. I think it's a
Yeah.
conversation that needs to happen, because
but we're moving towards this model of incorporating all care within the hospital, and maybe we should be thinking about removing the responsibilities of care. Because the thing that frustrates me is that the hospitals, every time they're under pressure, first thing they do is they cut primary care because it's losing for them.
Mhm.
And living under that threat is sometimes more,
But if we look at the continuum of care, it starts in primary care and ends up in your tertiary care place. So fracturing it more worries me, that there has to, I mean, when we think about a population and we think about a global budget, we think about the whole population of Wyndham County, where does it start, where does it end? I think it starts in primary care and it ends in tertiary care somewhere.
I believe.
I think we should have a conversation.
should.
Yeah.
Yeah, I think it's a conversation worth having. I think that, again, the transformation work should be having this conversation as well. I also think it plays into EHRs, right? So part of what I really appreciate about my primary care being affiliated with a hospital right now is my daughter has a specialist at UVMMC, and then she has her primary care in town. And then when we go to urgent care, the urgent care looks at the record and sees that reason why my daughter has a specialist and adjusts for that. And then the primary care doctor calls me the next morning to make sure that everything's okay. And so how can we potentially get the benefits of supporting our independent primary care providers, but also have that coordinated and talking to each other piece as well. So hospitals are doing a bunch right now. I have a whole separate list. I'm seeing that it's 2:00. So I want to go through this a little bit quickly. I just also want folks to understand that VAS is being proactive in this as well, in terms of, you've seen this slide before, but we are exploring a lot of different opportunities in terms of centralizing administrative functions, bed capacity tool, talent pipelines, interoperability for electronic medical records, which is right here. We have been talking with our IT directors. It does sound like the 4 big organizations that control our electronic medical records may be able to talk to each other. We are going to work on making that happen.
I think Daisy had a question.
Okay.
Go back one slide.
Yeah.
How many of those under the now have been initiated within the last like 6 months? Versus have you've been doing them before?
None of them have been done before. In terms of VAS, we haven't had.
Measuring financial outcomes before?
We have not been measuring financial outcomes before because that's largely been the sort of regulatory function. But we do think that there's a lot of value in getting an understanding about the financial outcomes and quality outcomes and access outcomes internally. So that is something that we're working on right now.
And then quality maternal health care, I hope that that's something that you've been doing before.
Not as VAS. That is, I will say that the Vermont program for quality in healthcare typically does the quality work. So what we would do is potentially partner with them on something like this. But they do the quality work with our hospitals.
So that's the renewed focus on it, would you say?
I don't know.
I guess I'm just, what I was looking for on this is, I guess I'm reflecting back on the slides that had sort of recommended, focus for us or something, and they were all around like reforms. They were all around insurance. And I'm kind of struggling to see where BOSS and the hospitals are showing that you've taken action, because I've been hearing that we're in a crisis for a long time, and hospitals and systems is not my area. And so I really look to folks in that seat for, the recommendations. And what I'm seeing is that we should look to the insurance companies. And I saw those bright pink bars. And I really feel like you're deflecting a lot of the responsibility for, improving our system and, the emergency that patients are in. that we should look to, the insurance companies for answers, and I just don't understand why that is.
So I should be clear, I have 2 pages of what the hospitals are doing right now to help the system, and it's another link on the website. This is stuff for VAS to be doing because we want to be proactive in this space too. And then we are also doing the hospital transformation feasibility work with the consultant.
Can I just ask real quickly, are you working with Vital at all
We do work with
for your interoperability work?
We will need to work with Vital for our interoperability work.
But you're not currently or presently?
We work with Vital a lot. My colleague Emma works with Vital a lot. I'm happy to come back with more information about that work.
And you need to have Vital in also, so.
Yes.
Yeah. Just talk with them about that.
Healthcare stewardship, again, VAS is hoping to work with clinicians on this in terms of reducing costs. And then workforce development as well.
Question.
Yeah. All right.
Are there hospitals in Vermont that utilize internal travel contracts as opposed to agencies for travel staff? Because I think that
Yes,
there's a
I
lower
think they
cost,
do.
isn't there?
Yes, yeah, there's a lower cost, and that was sort of the concept we were bringing to maybe the hospital association staffing pool, is have a platform where people who want flexible hours can just go on there, sign up for it, remain in Vermont. It's lower cost than going through a staffing agency, so reducing costs that way.
Okay,
So sort of taking that internal staffing pool and broadening it to the whole state, and maybe even beyond hospitals.
removing the agency from
Yes,
the equation.
yes,
Is that what the Indiana Resource
yes,
Program is?
yeah.
I really want to get to Blueprint and SASH.
Thank you. I appreciate it.
I do want to say one last thing. I'll say the same thing I said to AHS. I'm not seeing a lot of urgency. And a lot of your hospitals are in trouble. Okay.
They are doing the work. I will tell you that they are serving their communities every day. And I will also tell you that it's difficult to plan when we don't even know how we're going to get paid in the next 2 years.
Thank you.
Thanks.
I just need a minute.
Sure.
Thanks.
Yeah. For the committee, I want to let everyone, I mean, we were scheduled till 3, but I really think it's really important that we hear from both Blueprint and SASH and the important work that they're doing. So I'm going to allow them as much time as they need. And I feel like I've given everybody out early on Fridays for the last few Fridays, so I'm making up for this night. Last Friday. Well, that was the committee's fault.
Or not.
Okay, you mind just passing me that tissue box? Thanks. Appreciate it.
You're gonna make us try to.
I know. Pass it around.
Last time Mari asked me to bring my banjo next time I came back, so, no, I hope not, goodness. Should I just
Yes.
begin? Okay.
Yes.
Yes. Yeah, thank you. There are a couple new members that I haven't met before.
Do you want
If
to go around?
that would be lovely. Thank you so much.
Start over in our usual spot.
Hi, how are you? Lori Hogan, I represent this.
Hi, so Alyssa Goldman Bell's house.
Mari Curtis, Bristol.
Oh.
Oh, I just hold the tissue, Mari, but I'll use some.
Oh, okay.
Yeah, I use it. No, I just hold it. That's okay. It's like an old hanky.
Automatic.
Oh, thank you.
Thank you.
Eric Powers, Waterford, Barnet, Redgate.
I'm so sorry. Where?
Waterford, Barnet, Redgate.
Top of Medford, Barrytown, and Williams.
Alyssa Black, Essex Town.
Daisy Rebecca Winooski.
Wendy Criswell, I am here from Colchester.
Mhm. Thank you. Well, so nice to meet the new members. And Brian,
Yes, Brian Tina Burlington.
Brian, good to hear your voice. I'm John Soroyan. I'm the executive director for the Blueprint for Health. I can tell that this room has some acoustic warm spots. Representative Houghton, Page, and it appears I'm sitting in it now too. It's we wouldn't expect it from the shape of the room, but there's a warm kind of quality to the acoustics
It's really
here.
nice glow.
Right, right. So I'm a very loud speaker, so I'll try not to speak at my usual volume because I don't have to in this room. I'm the executive director of Blueprint for Health. I just celebrated my 3 years in this position. I began January 3rd of 2022, and it's 2025, so that's 3 years and a little bit, 28 days. My background is as a board certified pediatrician. I began my clinical work in New York City as a pediatric end-of-life care and pain management specialist at New York Presbyterian, on faculty at Columbia University Medical Center. And then in 2013, I moved to community practice of hospice, where I practiced hospice medicine in people's homes, wherever home is in Vermont and New Hampshire between 2013 and 2022 before coming into this role full-time with Agency of Human Services. So that's my background. Very nice to meet you. And Representative Black, Chair Black, I am going to, this is an overview. It's about 30 minutes or less, but I welcome however long you all have questions for, but this is very much an overview of the blueprint, and happy to come back in more depth in the future if that's what the committee wants. Now, I just have to advance my slides here. Let's see. There we go. Okay. The Blueprint for Health, 4 points to review, and I'll go into depth on all of them. But the 4 points that I really want to make, that I to begin and leave you with, if you will, is that the Blueprint for Health focuses on building best practices and prevention services in both primary and specialty care practices, and I'll go into greater depth about that. Being accessible to all patients, regardless of the payer. It's founded on the principles of patient-centered medical homes and multidisciplinary community health teams. And payers include Medicare, Medicaid, and commercial insurers. So again, those are my 4 overview points, and I'll go into all depth on all of them. The early history of the blueprint includes Blueprint for Health being codified into Vermont statute in 2006, Act 71 establishing the patient-centered medical home and community health teams. So let's see, that was 18 years ago. Is that right? Did I get that right? I think so. Maybe 17 and a half. The first pilot site in St. Johnsbury in 2008. Participation in the CMS multi-payer advanced primary care demonstration in 2010, and a shift to a statewide program under Act 128 in 2011. The Vermonter, I'm just, there's a part of my slide presentation here that's in my way. There we go. The part I want you all to focus on, and then I'm going to describe the concentric circles around it, is our Vermonter, me, you, us, our neighbors at the center, who seeks care a Blueprint participating practice, which I'll go over the criteria for. And around that Blueprint participating practice, I'm going to describe for you all the supports that occur. We actually have a program manager here today from Morrisville, Hannah Ansell. Thank you for being here. So Hannah is our program manager in the Morrisville Health Service area and works for Lamoille Health Partners. So thank you for coming in. I also didn't introduce Kara Hooper, who's our project administrator, who I can thank for these slides, in particular this graphic. So our program managers work with participating practices. They oversee our community health teams, which I'll go into, and also our quality improvement facilitators. The participating practices are divided geographically across the state, and I have a map coming up of administrative entities that receive funds from different payers and support community health team leaders, quality improvement facilitators, and program managers. So that I get you to the kind of the second to last of the circles from the middle. And around that is the team that sits at the Agency of Human Services, myself, our assistant directors, our data team, Kara, of overseeing and implementing the oversight of the program. There's other aspects to our executive committee, which Representative Houghton sits on, but really in one slide, I want you to sort of be able to organizationally, I learned visually and by reading, to understand how we're structured. So Vermonters engage in that practice. They're supported by program managers, quality improvement facilitators, and community health teams. And for organizational purposes, we divide the state into health service areas, in each of which is an entity, an administrative entity. Those are mapped for you on this slide. So Essex and Orleans County, for example, fall in the Newport Health Service area, and the administrative entity there is North Country Hospital. As I introduced Hannah at Lamoille Health Partners, that's the Morrisville Health Service area, and this is the organizational structure of our program. So there's the central oversight and support, but there's a lot of local oversight, support, and control over how funds are used as well. The four primary initiatives of the Blueprint for Health are the patient-centered medical home model that supports high-quality primary care, the community health teams, which links individuals to other specialty care, does care coordination, the hub and spoke system, which was founded on the team-based care principles surrounding the need not just for medication for opioid use disorder, but also counseling and nurse case management to give whole care to individuals with opioid use disorder, and the Pregnancy Intention Initiative, which helps provide access to services supporting pregnancy intention and family planning. So more in depth on patient-centered medical home. Chair Black, did you have a question?
Just listening intently.
I think I did that with you last year too. I think I thought you had a question and you didn't. I think I did that last year.
Maybe you can read.
My apologies. I cannot. No, I
That'd be a little
cannot. I thought we were just on the brink of a question, but obviously not. No, thank you.
Very avid.
Yeah, leaning in.
That's right.
So patient-centered medical homes is a model of primary care delivery that provides accessible, comprehensive, whole person centered care in a coordinated team-based fashion. It combines preventive care, acute and chronic disease management, and other services in a single setting. The recognition of that comes from the National Committee on Quality Assurance, which is used all over the country, and Vermont was a very early adopter for in those mid-2000 years to sustain recognition, a very rigorous process for all of the approximately 130 practices in the state of Vermont that are what we call Blueprint practices. So they all have to undergo that rigorous recognition process. There are multiple studies around patient-centered medical homes demonstrating improved clinical outcomes for patients, increased patient engagement in follow-up and treatment, and decreased utilization of the emergency department. More than 70% of Vermonters are seen in a Blueprint-supported patient-centered medical home. We know this from data that's reported by insurers to the Vermont Healthcare Uniform Reporting and Evaluation System. So that's really very much where the impact of our initiatives can be magnified. So our planning, figuring out funding, figuring out the delivery model, and then being able to extend it into practices all over the state and reach, I'd love to reach 100 or 95%, but to reach a significant, more than 70% of Vermonter number. Our community health teams are probably what's referred to most, since that's such a unique and really beloved part of our healthcare delivery in Vermont. Quite different from just about any other state in the US. Community health team members may include health educators, social workers or counselors that provide mental health and substance use or direct patient care. Care management and care coordination. Care management oftentimes being something longer term, care coordination sometimes being slightly shorter to medium term. Someone who's a panel manager who might look over everyone, for example, with a study result that indicates diabetes or diabetes that's early or not in good control. And community health workers. So I just wanted to sort of illustrate for you what the community health team composition would be is. So those team members identify root causes of things that might lead to health problems. One of the most common ones that I hear from teams is they don't have a refrigerator to keep their diabetes medication at the right temperature. Oh, that's a really important thing to identify as a cause and connect them with resources to get that in the home. That's just one example. Mental health needs that might come up in a visit that need 15 more minutes, 20 more minutes, 30 more minutes behind what was planned for the chief complaint that ended up being much more expansive than what it was is frequently noted by practice as value to a community health team member who's present in the clinic and available to address those needs in a more integrated way in the practice. And also engaging in screening. So screening for transportation problems, asking questions, just a fancy word for asking questions, in my opinion. Asking questions about, in a more uniform way, asking questions about transportation, housing, finances, food. And what we've called, and I graduated from medical school in 1999. I would have called team-based care biopsychosocial care in the 90s. It's very much referred to, and it's evolved into more things than just that, but very much care that's given it to a whole person, that's seen not just as a person with a disease-specific organ problem, but who are they? How are they? What is the state of their mental and physical health? And so they connect people. Yes, go ahead.
You done with that page?
Sure. No, you just asked me. It's fine.
Okay. What's that mean? No constipations are provided?
Sure. No cost to patients or providers. So for example, when I go to my visit, my practice, the Blueprint practice I go to bills my insurer. If I see a community health team member at that practice, there is no, again, it's kind of like a receipt. The claim, that's the fancy word for receipt in my simple mind. There's no claim generated. I don't get a bill. The insurance company doesn't get a bill for me meeting with that member of the community health team. And I can explain how it's funded. It's funded through a fancy prospective value-based per member per month payments, but there's no cost to me as the patient receiving these services, and the provider is receiving money to fund these individuals.
I think you do have a slide on your funding, right?
I'll talk about funding some. Yeah, I'll talk about funding some. Yeah, sure. Does that help a little bit? It's sort of hard for people to believe.
Well, in reality, I know that you have one of these in central Vermont.
Mhm.
And I was just asking myself, how would I know that I'm being I'm involved with one of these teams.
Yeah, no, that's, may I answer that question now? Oftentimes a person doesn't. The name tag that people wear, their ID in the hospital states the name of their employer. It doesn't say, and I'm not trying to tell a joke. It doesn't say 85% funded by the Blueprint. It doesn't say that. The monies that come into in that county, the hospital system, they take that and the employee becomes one of their own. They're a member of that team. They're not labeled sort of generally as Blueprint funded. And from my perspective as a physician, as a patient, as a dad, all that, that's fine with me. I actually prefer people get taken care of without really knowing who's funding whom on a team. It leads to sort of the Blueprint maybe not having, and this is just my way of thinking about it, not having a fingerprint sometimes, so that people will be receiving, even clinicians sometimes I've talked to don't realize that someone in their practice has been funded by the Blueprint since like 2013. But that's, again, a busy clinician, focus on the person in front of you, team member here. That, for me, that's okay. I don't expect clinicians or patients to really understand all the payment stuff behind the scenes. But I mean, I could certainly show, I mean, we won't do it now, but I could show you a list of every single person who's funded in that hospital system or that practice, whether it's a federally qualified health center, an independent practice, a naturopath. If they're a Blueprint practice, they do receive some funds. So, yes, please.
So without that I'm sorry.
Go ahead.
Without identifying who these people are,
Okay.
I've never been seen by anybody else besides my doctor.
Yeah.
How are you screening?
Yes, no, that's a great question. So there's screening the way I was taught or learned via interview. And there's screening via different forms of questionnaires that are given once a year.
So any questions
there's
that you're asking
there's
about-
variability. There's variability. And I have a slide a little further on about the number of Vermonters who are seen by community health team members. That is data that we've been collecting now for about 2.5 years. So that's just the answer. So I should probably keep moving on. Otherwise I get talking a lot. And then suddenly it's 2:30. Oh my goodness, look at that. It's 2:30. I was guessing the time and it actually is 2:30. So the SPOKE initiative, Medications for Opioid Use Disorder, is a shared program between the Department of Health and the Blueprint. The Department of Health oversees our opioid treatment programs, so-called hubs. That's the word that's used in Vermont. And typically, a hub is a more intensive form of treatment, frequently where methadone is dispensed and the individual needs to be seen on a daily or frequently basis. There's variation there, but that's typical of a hub. It's a higher level of care. Again, this language is very unique to Vermont. A SPOKE is a practice setting. It can be in primary care. It also can be an addiction specialty practice too, which is pretty cool. So specialty physician. And that's an office-based setting, like a doctor's office that's not necessarily a designated hub. There are 91 SPOKE practices throughout Vermont, and through funding, like I'll explain in just a bit, they are able to hire a nurse care coordinator to assist with the care of that person, the whole person, not just the medication they need to prevent withdrawal of the opioid use disorder, and also pay for a counselor to meet their other needs, to make sure that their treatment of their use disorder is not just with drugs, but also with the choices they're making, their employment, their own coping mechanisms. The Pregnancy Intention Initiative, also quite unique to Vermont, really focuses on comprehensive family planning with the goal of increasing access to preconception counseling by asking about someone's intention to become pregnant in the coming months. It improves maternal and infant outcomes, and and really offers same-day access to long-acting reversible contraceptives. We also host training for physician assistants, nurse practitioners, physicians, osteopaths several times a year in the insertion or the procedure of utilizing a long-acting reversible contraceptive. Paired with that medical care, and this is a theme that I hope you're hearing, and I hope I'm doing a good job describing it, paired with the medical home, the spokes, the pregnancy intention initiative, paired with that medical work is the asking questions, the screening, the referrals, brief interventions, the care coordination. So it's a very much an extension of the foundation of our program. So Chair Black, I'll get into a little more detail on this, but I want to just put it up on the screen. So the payments come from our large commercial insurers into the patient-centered medical home and community health team initiatives. The commercial payers, and I can explain this in a number of different ways, but let me go over the overview first. It's based on the number of patients attributed to that practice. And the attribution method is a procedure that the insurers do to identify that that is the person's medical home. That's the primary place that they're seen in a 2-year look back. So they calculate that number and pay $3 per member per month, which can add up between Medicaid, Medicare, and commercials. If a practice has about 2,300 patients, that can add up to about $7,500 monthly for being a patient-centered medical home, to support all the hard work they do to be recognized as a patient-centered medical home. And they can spend that money to support their practice. So that's just a rough example of a practice that would have 2,300 attributed patients. The community health team payments are also made by the large commercial insurers in the state, Medicaid and Medicare. And for example, an administrative entity, let's use Morrisville. Let's use Lamoille Health Partners. Their administrative entity, if there's 13,000, and I don't know if this is the number, I'm just saying part of the state. If there's 13,000 people attributed in that health service area, they would receive around $107,000 every quarter to pay their community health team members and hire them. So the payments come in. This is in statute, the contributions from the commercials and Medicaid. The payments come in based on with the community health teams, it's $2.77 per month. They come every quarter. They're reliable, they're prospective, they're value-based. They are not fee for service. So to the patient, to the provider, there is not a bill that the patient gets after seeing a community health team. There's not a bill that the provider generates after walking them down the hallway to talk to the counselor for 15 minutes. There's a clinical note, saw a patient, but there's not a bill that's generated. Yes, please.
So this has been a concern over the years, and I'm wondering how we're doing on this, and if it's being tracked. Because of movement into the self-insured market and movement from Medicare to the Medicare
Yes.
Advantage, that the pool of insurers paying in is getting smaller and smaller, but the services are available to everyone.
And the needs are very high.
And the needs are high. So I'm wondering where you are, like level right now.
Sure.
And where it's trending.
I can give you, I don't know if I can answer those exact questions, Representative Black, but let me try to at least give you the first thought that came to my mind as you started speaking. So I believe it was 2.5 years ago, the legislature had the Blueprint Generator report about this topic. It's the Act 51 report. And I didn't prepare slides or a review or my colleague who I would present with, but I'd be happy to come back and talk about some of the options that the Blueprint laid out in the Act 51 report to begin generating discussions about future ways of ensuring greater participation in our programs. I can show you some of the numbers about our community health team participation. I don't today have any trending of Medicare Advantage or other things, but I think I could come back with each of those things. Certainly a review of the Act 51 report I could come back with, but the legislature actually had us write a report about this topic and come up with other ways of funding the blueprint that might evolve us to reflect the changes in these markets. This model is still extremely useful and showing results, but maybe after 15 to 20 years.
Yeah, maybe the funding model should.
Yeah, looked at, but together.
Yeah.
So quotes, and then I'll end. I'm sorry, Kim, that I went too long. I think I'm still just under 30 minutes though. So, in their own words. So, this is a spoke counselor. So someone who works with individuals who have opioid use disorder. And this is from the Barrie Health Service area. The work we are able to provide is critical to the support of patients and our providers and our local spokes. I have had primary care providers tell me this is the most rewarding aspect of their job, and patients say, "You've helped save my life." From a community health team staff member in Brattleboro, we are able to meet with people who need it, and we are connected right to primary care so they feel comfortable meeting with us. There also isn't a copay for our support, so they don't have to worry about the money component. I know we are helping people, and it wouldn't be possible without the blueprint. And then finally, from a pregnancy intention initiative worker in the Burlington Health Service area, our wraparound care had the benefits of preventing an emergency department visit, a potentially lengthy hospital admission, and increased hospital costs. These quotes come from our annual report, about which I'm about to submit in just the next hour or two. But our past 2 years of annual reports are very full of quotes from all the health service areas, both patients and providers, in terms of impact. This is a look at the number of individuals seen by community health teams going back to the fourth quarter of 2023. The fourth quarter of 2024 is not yet complete. Just for perspective, this is the unique number of individuals seen, but in quarter 3 of 2024, while that represents 26,000 unique individuals, in terms of the average time that they're seen, it's probably 75,000 points of contact or more for that group of 26,000. As Chair Black was saying, we know that the payers in are decreasing. We know that the needs are increasing simultaneously. So I don't want, even though I don't write it on this slide, I don't want you to think this is just sheer numbers of individuals. This is a magnified by 2 to 3 times in terms of points of contact. And we don't measure how long each visit takes. If they need to be spoken to for 2 hours on the phone or 15 minutes, that's up to the community health team member. Representative Houghton, I can remember the first time I showed you this slide. So this is a divvying up of, it's a happy memory.
It is, yes.
Yeah, you like this slide.
I did.
And it's reflective of the insurance distribution that you've heard from Voz and others today, a third. So a third Medicaid, a third commercials, and a third Medicare. That varies, I know, from year to year. And as the arrows and the asterisks and the double asterisks, it's important to note that this includes Medicare Advantage. And then small insurers too. Small insurers don't pay into the Blueprint for Health. Medicare Advantage does not pay into the Blueprint for Health. Self-funded plans have the option to. And this is our FTE across the state.
Yeah, go ahead, sure, please go ahead.
Do we know, so do you know what percentage of self-funds do? You may not, I mean, it may not be something that. Probably just baked in.
I'll talk to Addie and Caleb and the rest. And I think what's difficult, Representative Houghton, is that the VCure system, the claims-based system, does not, they're exempt following the Supreme Court decision about 7 or 8 years ago. They're exempt from having to report to Vermont's health claims, a uniform reporting system. So it's
Probably doubtful to have. Thank you for that reminder.
It's okay. This is the FTE. is really an important, I think, slide to show that these are individuals working on behalf of our patients. And I think, yeah, okay. So this is my penultimate slide, but I'm just going to read it because these are really meaningful things, especially on a Friday afternoon. You supported me with compassion and patience. Your coordinator provided us with options and connected us to essential resources exactly when we needed them. Every member of your team has been extraordinary, offering support to our family at each step. We extend heartfelt gratitude for everything you do. This is a patient who was served by a Blueprint Community Health team member. I want to thank my team, all of our field staff leaders across the state. And I think I'm going to unshare there. That's okay. Any other questions?
Questions? Thank you. Thank you for coming in.
Yeah.
Thank you for providing us with some positivity at the end.
Yes, and I'm happy to go into more detail about things. I really aim to be an overview because I know you have a lot of people to hear from. So
Great work that you do.
Thank you.
Blueprint is vital.
And the great care.
Nice to meet you in person.
Oh, here, you can share.
right, I'm not.
That's my space. Yeah. Oh, yeah, oh, that's space. Yeah.
Whatever works for you, right? It's just all virtual.
Yeah, you should be fine.
Thank you. I like watching you.
I will need to see it though.
I know.
So good afternoon. Should I just go ahead and get started? Okay, so good afternoon, everyone. Thank you so much for having us. I am sorry we are the ones that are keeping you between on a Friday afternoon being here and leaving. I am Kim Fitzgerald, the CEO for Cathedral Square, and I am joined by Liz Genge, who is our director of SASH. I have been with Cathedral Square 25 years. I've been in the CEO role for 10, actually 15. And Liz has been with us for 3, just to give you a little perspective. So our goal today is to give you kind of a quick overview of the history of SASH. I wanted to kind of like level, set the playing field, I guess, and some data points, current data points. And then I will turn it over to Liz to give you some initiatives that we're working on to build upon the platform of SASH. That all sound good? Okay, great. All right, so a little bit about the history of SASH. So in the early 2000s, Cathedral Square opened the first assisted living in the state of Vermont. And we realized we could not build enough assisted living to meet the growing needs of the aging demographics in the state of Vermont. So we thought, oh my goodness, what are we going to do? We have hundreds and hundreds of people living in our independent housing sites. Where are they going to go when they need more care? Where are they going to have Medicaid slots kind of available for them? And so we went to our residents at our Heidenberg location back in 2009 and said, oh, what did we say? I don't know. So we said to our Heidenberg residents, will you help us create something for you? It's really about, something that will help you stay here safely and securely for the long term. And we were so fortunate because 75% of our residents said, yes, we will help you. They had no idea what they were getting themselves into, but they said they will help. At the same time, we went out to community service agencies and said, will you help us at the same time to tell us what you're seeing? Where are the gaps in the system? Where are the things that are just kind of falling through? And Wendy was part of that design team, so that's really exciting.
Excites me too.
Yeah. Oh, I'm so excited. And really that was for a full year. We worked on the design with the design team and with our residents to determine what was needed. And our residents said to us, we want more nursing time. So Cathedral Square had always had an hour, maybe 2 if we were lucky, within our property budgets to support our residents. And they were like, we want more of that time. Having that nurse on site, who we know, who we can ask questions to, who's available a lot more than anybody else, is so important to us. So can you have more nursing time? The other thing is care coordination. And I know this word's been used a lot today since I've been here. And it really, in this regard, means more of kind of just being there for everything and anything. And it can be to set up like a referral to other services. It can be to just listen. It can be to help support and coach. So it's kind of a very wide open term, the way we use it. So needless to say, we started this at Heidelberg with 40 hours of a SASH coordinator or a care coordinator and 10 hours of a wellness nurse. And we always planned on this being population health based. So panels of 70 to 100 people would be what that full-time SASH coordinator and part-time wellness nurse would cover or oversee. And that in that very first year of piloting that, we saw by just adding those hours, we saw a reduction in the amount the ambulance came to Heidelberg and brought people to the emergency room immediately. Like, it was incredible. So by 2011, we had come to the Blueprint for Health. And at that time, the director was Craig Jones. And we explained this model to him. And he said, oh my goodness, you are where the social determinants of health happen. You are in the home. I want to add you to the Blueprint. Probably I'm making it sound easier than it was, but you get my point. I want to add you to the Blueprint for Health and be extenders of the community health teams that you were just hearing about from John. And so he added us to the MAPCP demonstration, and we started receiving Medicare dollars in 2011 to pay for that nurse and that care coordinator. That's it. They don't pay anything else, but just for those two positions. And we were capped at 54 panels. So we were 54 panels for many, many years. We then transitioned when the MAPCP demonstration ended and went under the all-payer model, under which now we receive our funding through that model under the ACO OneCare. So they send us the money directly. And that has been true, though, 54 panels this entire time until just in 2022. We have been receiving very modest increases through OneCare, about 3%, not every year, but most years. And we saved a couple of those years of increases to actually expand, to add 6 new half panels, so really 3 full panels. So now we're up to 57 panels in the state from the 54 that we were at previously. We will get to a little bit more about all these other pilots you see here when Liz does her presentation. So I'll skip over that for now. So here's just a graphic version, a visual version for you to see that all of those little yellow stars represent our housing hubs across the state where SASH services are offered. Now, when we started receiving those Medicare dollars back in 2011, they said, we don't want you to just serve the people in your congregate housing settings, even though that's where we started. We started at Heidelberg, that's what we're planning. They said, oh no, we want you to not discriminate based on where somebody lives. We want you to go out in the surrounding community as well. So even though you see these stars, we're also serving people, around those stars as well. And the partnership is critically important to SASH and the work that we do. So we partner and collaborate with home health agencies, mental health agencies, the hospital, the community health teams, a variety of partners that support this. And one of those things is that's what we learned during the design team year was that we had a lot of services coming in, but they weren't talking to each other. And we didn't know who might have come and seen PEG. 3 different people might have come and seen PEG, but they weren't all talking. And so the beautiful thing I think that this model did is really bring all of those partners together. We have team meetings. We all talk about our group of people that we're overseeing and how best efficiently and effectively we can care for them. And so we might be at a meeting where the home health agency says, I'm doing this with PEG. And then SASH may say, well, I've been doing this. And we're collaborating those services, again, to avoid duplication and to reduce redundancy and also create efficiencies. All right, so this is a little bit of a recap again. The SASH participant is always in the middle. We like to show this picture as in the driver's seat and in the middle of the circle, of course, with that care coordinator, SASH coordinator, with that wellness nurse, with those team of partners. And then we've also been able to add mental health clinicians in some of our panels. Liz will talk a little bit more about that. And then the panel of participants. So we deal with the participants one-on-one. So we do an annual assessment every year of each of our participants. So we get very individualized information. But then as that population health approach, we look at the whole panel together. So if we see that there's a high proponent of diabetes, for example, in a panel, then we'll bring programming to all of those people to say, okay, what if you're cooking for one as a diabetic? And now that whole group is receiving that program. It's not just one-on-one services. Again, very, very efficient. So because we were under the MAPCP, part of that funding was an evaluation. So we were rigorously evaluated by a third-party evaluator, a national firm, who really looked at us over 5 years. And what they found is that SASH, as compared to a control group, with the only difference being SASH or not having SASH, was that we were saving upwards of $1,400 per person per year in Medicare savings. And what those evaluators said is they had never seen this before. In fact, in their review, they were lucky if they saw programs that broke even, like even that was pretty unusual. But to actually see a model that actually bent the cost curve and reduced expenditures was just huge. They did a little bit of review on our Medicaid participants at the end. So it's a very small review, but they did also find there was Medicaid savings as well in those participants of upwards of $400 per participant. And that was really about them staying in their independent living homes, whether that be with us in an apartment or their own single family home, versus having to move to a long-term care setting. We're prolonging that transition. This is just a quick participant profile. This very much parallels our independent housing and who we're serving in the sense of it's mostly women. That's just kind of our reality. So 70% women. Not surprised for you all that, over 65 is the majority of our people. On Medicare is the majority of our people. We do, though, have some duals, so both Medicaid and Medicare. That's because many of our housing communities, our congregate housing communities, also serve disabled, so young disabled. And anybody who lives in one of those nonprofit housing communities is eligible to participate in SASH. You only have to be on Medicare if you live out in the surrounding community. So since our inception, we started out with those 59 participants at Heidelberg, and we have now close to 5,000 across the state. And we estimate we're over 12,000 participants that we've engaged with since we started. A little bit about our participants today. So bring this right back to who we're serving. So our top 3 chronic conditions, as you can see there, high blood pressure, osteoarthritis, and high cholesterol. The high cholesterol actually just bumped up. We did have chronic conditions, chronic pain as our top 3, and that's fallen down a little bit, which is that might actually be a good thing. But what I really wanted to point out here is that nationally, people on Medicare, 52% have 3 or more chronic conditions, whereas our SASH participants are 85% have 3 or more chronic conditions. So we are serving a much higher need population. Median number of chronic conditions per participant, 8. So, and you also can see the age span here where we have 22, again, young disabled, all the way through 104, with our average age being 73. Next up is a really very focused work we did in partnership with the Vermont Department of Health on hypertension, on high blood pressure, as that is our condition. And you'll notice here in the orange and red box, those are high stage 1, stage 2 high blood pressure. And in this pilot, we had almost 900 SASH participants who didn't even realize that they had high blood pressure. So we were able to help them identify the fact that they did. We were able to get them blood pressure cuffs. We were able to get them diagnosed and treated, and then helping them manage theirs. And you can see over on the right-hand corner, the reduction in the systolic and diastolic pressures, which I'm not a nurse, but I'm told it's just phenomenal. That is amazing that we've been able to kind of reduce that in just over 3 years. So a relatively short period of time and really remarkable results. So very, very proud about that. And again, doing these quickly. So also falls. You may well know that state of Vermont is very high on the risk for falls, very concerning, of course, across the state. And so that's another area we've really been working very diligently on. And so you can see in 2022, we had 54% of our participants who said they had fallen in the past year, and we've been able to reduce that down to less than 50%, 49%. Again, another very hard target to move. So very proud about those results. Obviously, we don't want 50% of our participants falling either. So it's something we still want to be working on. And we are in the home, so we are looking for trip hazards. We are helping on when you're getting up and out those transition spots that are really your high risk fall areas. To try to make this number go down even more. So again, I sped through that, but I know our time is short, so I'm going to then pass it over.
I wish Kim was always with me when I talk about that. That was a great history. So I'll just continue on. We're more than halfway through, to be honest with you. So an integral part that Kim mentioned is group programming. So we do bring programming to the SASH sites, exercise programming, health education, arts and crafts, and social activities. And I just wanted to mention, like one recent one is actually, we're doing square dancing at Allard Square in South Burlington. And one of the gentlemen who just recently lost his wife, he and his wife were participants, and he had the idea to do it. So he's like, I actually call square dancing. And so just like the social connectedness of that, and bringing him as a new widow to come out and do something like that. We are seeing a positive trend over the last few years on our participants that are screening as lonely. So we want to keep up that momentum, and it's a priority for us. And we do hundreds of around the state falls prevention work. I'm sure you're familiar with the Tai Chi, Matter of Balance, and we do that either with our own staff. We have over 105 staff around the state, or we work with the councils on aging, or who might be in the region who are trained in those evidence-based programs. So that's great. The first pilot, the few pilots I wanted to share with you all is using a participation waiver through OneCare Vermont. And that means that we're able to have our SASH wellness nurses complete annual Medicare wellness visits that primary care offices are doing, but in the home. So we're already in the home. Nurses have relationships with participants. And so it's really been a great startup. Late last year, we are using the 3 nurses at Cathedral Square. We're starting relatively small. We're working in partnership with Community Health Centers of Burlington and Apple Tree Bay, both in Chittenden County. We're using their EMR system. They're learning how to use that with PCP, and it's been positive. Like one example, one of the nurses in December was meeting with somebody for their visit, and she said, "I just have this annoying rash on my stomach. It's been kind of persistent." Oh, really? And then she talked with Dr. Sokol, who was the person at CHCB that same day, who was able to follow up, and she texted back, "Thank you so much for letting me know that." So they connected. So just like a little flavor of how it could just be more efficient when we're doing that. And it helps the primary care as well to get
And
things
some
done.
people who've never, ever had their annual Medicare wellness visit before is having it with us.
May I ask, are you being reimbursed separately for the annual wellness visit? In
So the-
addition to your other funding that you
The
received?
primary care provider is billing as though that visit happened in their own home, so they're billing on that side. But our nurses are being paid under the waiver through OneCare.
Thank
It's a
you.
grant.
Did you, Lori?
Are you, planning on what happens to this when OneCare goes away?
Well, yeah, I mean, the reality is what we have learned through the years is we always try to pilot something on a small scale. And then our hope is if it goes well to really expand it. So that's really what we would love to happen. We would love to have this be part of the AHEAD model. It makes sense from a PCP perspective that, from what I'm hearing, a lot of the primary care practices aren't doing a lot of these annual Medicare wellness visits. It's kind of low on their radar, even though we know that the federal government really would like to have these done, and they're really beneficial and very preventative in nature. And so we would love to have it be part of that, to be expanded more than anything.
It takes a good hour at least to do these. So that's the time that our nurses can do. Okay, so the next. So October marked our first year of expanding another pilot. I was actually here 2 years ago with Molly Dugan, who was our pioneering SASH director. And we've been working with the Howard Center at 2 panels in Burlington, and we embedded a mental health clinician. And she's there to provide one-on-one therapy in groups. She has her office in the buildings. What's beautiful is that she doesn't have to bill, so she can be offering these things. Another highlight before we get into the recent expansion data is that year over year, we're averaging that 50% of the men in these panels are seeking therapy and going to groups. So that's higher on average. So we think that's cool. Like just the accessibility of having somebody that you're familiar with, not to drive to the Howard Center, that's definitely making a difference. So we've engaged this first year with Washington County Mental Health, Northeast Kingdom Human Services, and another panel with Howard Center. And we were pleased at the results. So with those panels, over 30% of the participants did engage with the clinician. 87% of those participants were able to have a conversation on the phone or in person with that clinician within 3 business days of a referral to their coordinator or their nurse or their self-referral. highlight the number of touches. Over 1,300 clinician visits were logged in of participants in this first year. And they weren't all hired on October 1st. So we have like some staggering. So that's really, really great. And then we did do some preliminary surveys of the panels that were getting the clinician. And we learned that percent of participants agreeing that there's acceptance and support for emotional health needs in their buildings rose from 52% to 89%. Some of the properties like Decker Towers in Burlington is a great, I think, everyone's making a great impact. But it's just really nice to just be quietly in there and just working with residents around the state to be offering that. So the next, moving on. We're in year 3 of a pilot called SASH for All. This is in Brattleboro. So the same model, SASH, applies to the properties in Brattleboro, which it's multifamily, serves all ages, and it's free and voluntary. So we're really finding that one of the lead results that we're preventing homelessness. It's not, hypertension necessarily in this population yet, but it's been what we're seeing, and that's what we're focusing on. We're providing access to healthcare, not only because the same team with the clinician, the community health worker, coordinator, and the community health worker are the same, and wellness nurse are in the buildings. We're striving to shift from emergency services to preventative care by doing the programming, et cetera. The SASH team here works with us. You see all the partners on the screen the second Friday of every month. So they're doing those care coordination meetings or service coordination meetings on a regular basis. And then people that aren't signed on to the SASH for All model, the schools or the police department or whoever, they're also referring, joining meetings as possible. And Brattleboro is it seems to be a really, really connected, great community. So it's been going really well. Some data I'll show you on the next slide of who's participating. 235 residents in 2024 participated, 119 adults, and 85 are full participants. Full participants, I just mean they signed on their use and disclosure and they're doing those wellness assessments. The other adults just aren't ready to either want to sign on, but they're still going to group programming. They still might be getting help with rent support, et cetera. The age in the top left here, the average age of the adult is 43 of our participants this time. And what's interesting is that the population is more diverse than what we see in our typical SASH population in the state of Vermont, with 21% identifying as BIPOC. And then year 2 outcomes and the data profile. I just wanted to highlight what's in blue, that just kind of sharing feel like we're in the right place at the right time. Like 87% of the residents are qualified for Medicaid. 87% are experiencing food insecurity. 78% are missing appointments due to lack of transportation, and that could mean go to work or an appointment at your child's school. 53% is presented to the ED in the last 12 months. That shocked us, but also didn't, because we knew this is where we wanted to be. It's more preventative. 26% are high utilizers of the emergency department, and 50% of the participants, the adults, say that their health is either fair or poor. So it's like a snapshot. And then you'll see to date some of the things that the teams have, the outcomes is 19 evictions were prevented since we were staffed up. Over 160 social connection activities and group programs. And now the communities are doing them on their own. They're scheduling them and they're inviting staff. So it's a great turn. They just had a community dinner last night. Over 50 people attended. And it's not only for social connectedness that we talked about earlier, but just those neighborhood connections and maybe less conflict that comes into for housing communities. And then I wanted to also shout out, we do a lot of referrals. The top 3 referrals our teams are making is financial assistance, mental health, and food assistance. There's one last, So this past summer, you see we're getting an award there. SASH was recognized for controlling hypertension, like Kim mentioned, in older adults. And we were recognized by IPRO, they're a federal program that's focused on improving quality of care to Medicare recipients around the country. And those two women are our two registered nurses that are on the SASH administrative team, and they do a lot of work with our SASHs around the state, with our nurses around the state. And then the last initiative I wanted to highlight was our dental clinics. So we know that half of our SASH participants have a dental provider, half of them, and 42% of our participants had gone and seen a dental provider in the last year. So Michael Messina, he's a dental hygienist, and he brought his chair and he brought his cleaning, and he went to the sites and he did fluoride treatments. And I can see here we had 12 clinics. It was in 4 counties. We're continuing this partnership with him. This is another initiative that's additionally funded by the Vermont Department of Health. We have like small grants with them on special projects, and then 102 cleanings were performed in 2024. And then to close out, I just wanted to share our SASH coordinator in Barry at Barry Housing Authority. She emailed the team and says, I have related to the dental clinic. I have one participant who had not seen a dentist in many, many years due to lack of transportation, her anxiety, and her fear that it was just going to hurt. The participant is praying that Michael comes back because she wants him to clean her teeth again. So that's the questions.
Any questions? Robert?
On the page where it says effective in preventing homelessness. Is that where you talk about the evictions?
Yes,
Okay, so they're not homeless then.
they're not. So a lot of these are people that are already residing in the affordable housing communities. A lot of people are coming from homelessness. Now, like we have, and you can maybe quote, like we have about 25 or 30% of our residents that are previously homeless.
Cathedral Square, I don't know about the
Yeah.
statewide SASH participation, but I can speak for Cathedral Square. We have over 20% who reside with us who were formerly homeless. But one of the things that we also see happen is people from homelessness can move in, but then if they don't get the supports they need, they're going right back, they get evicted and they go right back on the street. So a lot of our work is to help them remain housed for the long term. So that's what SASH for All is very much focused on.
Daisy.
First of all, thank you for the amazing work that you're doing. Just whenever you're here, I just feel so proud of what you're doing out there, and just a lot of gratitude. What threats are there to the program?
Okay. I mean, the real thing, we're very pleased right today because we're learning that our funding mechanism has been what's been so scary for us, right? And honestly, through all of our now 15 years within SASH, it feels like we're constantly spending so much time on the funding piece, which of course takes away from the actual work. But so we know that we look like we're going to be embedded within the AHEAD model, right? And the state is moving forward with that. So we were worried about the gap year, but we've just learned that the governor has that in his budget. So we're very, very excited about that. And so that is for all of that I'm talking about is for our traditional SASH. What we still would like is to be able, all these new initiatives, we would really like, we've shown the proofs in the pudding, right? We've shown that they work, they're successful. We would love to get them funded because we just believe that you build on the things that work. And, rather than trying new things that you're unsure about, let's build on what we do know. And these are all really working. And we already have all the infrastructure in place, to do them and to train and support. So we just would love more supports in that area, more funding supports in that area, because we think it's what makes the most efficient sense.
Are you going to be coming to somebody with a number?
Yeah. I was thinking, I don't think it's hit this committee. So yes, we absolutely can.
Maybe it's human services.
No, I believe SASH is
us.
Yeah, because
Okay, then absolutely. Yes, we would love to, because we would love to be, like I said, be able to expand all of these things. And then similar to what you probably hear about everything is, and I didn't say a lot of this in the beginning, but those 54 panels originally, we were capped not only on the 54, but also our funding source. So we started out with basically $70,000 per panel. And that was reduced because there was a sequestration. So it actually went down to 68,600, which we had for like 10 years with no increases. And we all know that that really means decreases because salaries and benefits are going up every single year. So we'd also like to make sure that we're seeing some sort of annual increase within those figures too, just so we can keep up with, the work that we are doing. And the other thing I didn't mention either, I don't think, because I was trying to go really quickly, is that because I don't think I said this, so I did, you can tell me, but we've also replicated in other states. Because, and to your point, just being so proud of this being a Vermont homegrown product, right? We replicated into Rhode Island. And so Satch has Rhode Island and they've expanded. They're also looking about their funding source and would love to be added. They're also looking at AHEAD. And so they're looking to see if they can add Satch within their AHEAD model. And we have also replicated in Minnesota. Unfortunately, they had 3 years worth of funding, so they're no longer doing Satch, but they would if they could have the funding source to do so.
Well, thank you for coming in. Thank you for actually ending our week on a high note.
And we're happy to come back if we're too quick and there's anything else you want us to dive deeper into.
No, you do wonderful work.
Thank you.
Thank you.
Appreciate
Thanks for
it.
your time.
Thank you.
Thank you. And we can go